Actually, Dr. Kim has reviewed almost all my topics, so maybe I can end it briefly. So actually, my topic was ACS patients, but Dr. Kyuk Chang wanted us to talk about product chip, so I made a modification to chip ACS patients. So complex high-risk indicated PCI patients, you can see one score dramatically increases basis per score. And as you can see, we have to think about ischemic and bleeding risk. And the bleeding events after PCI is important after the 30 days, 1 month, because before 1 month, ischemic event rate usually is more higher than the bleeding event rate. So there are many studies towards to minimize risk of bleeding. As you can see, now these pink studies, trials of aspirin-free strategies are increasing. So this treatment team is 38 in plateau trials. Dr. Chan-Jun Kim always reviews. So I will talk about ESA-REACT 5, TICA versus Prascular. And you can see in the composite of death, MI or stroke, Prascular showed a better effect than primary endpoint, and safety endpoint, there was no difference in the PARC type 3 or 5 bleeding. So this is the current ESC guidelines. So we have to choose in ACS, DAPT, then default strategy for the first 12 months after ACS is aspirin plus P2Y12 inhibitor, class 1. But in the ACS Prascular ticagrelor, proceeding to PCI, Prascular is maybe better than ticagrelor, class 2A. So there are many strategies for the escalation of antiplatelet therapies. So it can be shortening of DAPT or changing the P2Y12 inhibition by guided or unguided dose reducing. So I'm going to show some meta-analysis of studies because there are many studies regarding this area. One meta-analysis was introduced in 2022. Meta-analysis of 29 studies. This is de-escalation, and this is short DAPT. Short DAPT means removing aspirin, or removing P2Y12 inhibitor. So you can see the favors de-escalation is in the NACE, net adverse clinical events, but bleeding is more favorable to short DAPT. So maybe removing aspirin or P2Y12 inhibitor reduces major bleeding, but it can cause more NACE. There is another network meta-analysis with 32 RCTs with more than 10,000 people for the ACS patients in the 2023. So you can see short DAPT with aspirin, short DAPT with P2Y12 inhibitor, standard DAPT with low dose Prascular, standard DAPT with Prascular, standard DAPT with TICA, unguided de-escalation, extended DAPT, guided selection. Very complicated, but in this, there is a P-score. P-score higher means it's better, safer efficacy. So in the MACE, unguided de-escalation and guided selection has the most better MACE. All-cause death is better in the short DAPT group with P2Y12 inhibitor. Cardiovascular death was best in the unguided de-escalator group and the short DAPT P2Y12 inhibitor. And the MI, as you can see, extended DAPT is better in the MI. Stroke, guided selection is better, and extended DAPT is second. In stent thrombosis, as you can almost think about, extended DAPT is the best. And major or minor bleeding and more major bleeding has some difficulties, and unguided de-escalation is best in major or minor bleeding, but major bleeding is best in the short DAPT group. So this is a little bit different and complicated. But as you can see, like this in the conclusion, switching, dose reduction, discontinuation, switching and reduction as de-escalation, discontinuation as a short DAPT, you can see there is no statistically difference between two, but bleeding has a tendency to better in the shortening of the group, but the MACE is maybe better in the de-escalation or the switch group. And there is another network meta-analysis presented this year. So you can see it's very complicated. 32 RCTs, more than 10,000 people. DAPT with aspirin clopidogrel is in the middle as the conventional group. There are very other groups. So as you can see, reference is DAPT for 12 months. So high potency DAPT means 12 per-square or 12 ticagrelor. MACE is lower, but bleeding is higher, as you can think. High to low potency DAPT, tica, per-square, switch to clopidogrel, you can see MACE is better, bleeding is better. So, and then low dose DAPT, 5 milli per-square for 12 months, MACE a little bit better, bleeding a little bit better. Short duration DAPT, you can see tica 3 months, then tica only, MACE, bleeding. So in this chart, you can see DAPT 12 months for aspirin clopidogrel as a reference. This is the reference for bleeding. This is the reference for the MACE. You can see tica per-square 12 months, it can reduce MACE, but it causes bleeding. So maybe in this journal, they say high to low potency DAPT 12 months may be the best because bleeding is almost same as the reference and has a lesser MACE. So DAPT 3 for tica is very good for, you can see the bleeding and MACE also increased. But 1 month of clopidogrel is reduced bleeding and it can cause MACE. So this is the part we have to very think about our future strategies. So the current ESH guidelines shows that shortening of 3 or 6 months, de-escalation can be done, and in high bleeding risk, shortening 1 month can be done too. So how about potent P2Y12 inhibitor monotherapy in CHIP ACS? So as I said before, ESR React 5 subgroup analysis, 84% have had PCI, and you can see there is a significant reduction in per-square group in PCI with ESR React subgroup analysis, but there was no difference in the bleeding. And in the subgroup analysis, there was complex PCI defined as multifacet more than 3 stents, more than 3 lesions, and total stent length over than 60 millimeters. And after moving, you can see complex PCI per-square showed better, but not significant. In the non-complex PCI group, was very showed significant reduction in the per-square group. Bleeding, both groups did not have any difference between tica and per-square. And in the Prometheus study, there was a about 48.9 complex and 51% non-complex PCIs. But in the complex, non-complex, red is the complex PCI. You can see in the 90 days and the 1 year, even in the 90 days, this favors per-square. In the 1 year, MACE, this showed favor to per-square. Bleeding, both groups did not really had a difference. Aspirin, actually, like in this both groups, you can see there has a little additional inhibition of platelet aggregation in the presence of P2Y12 inhibitors. And as Dr. Chan-Jung Kim reviewed before, Smart Choice trial showed non-inferior composite endpoint of 3 months stopped. Bleeding was lower. And the stopped up to date trial, it showed a primary endpoint, major secondary cardiovascular, no difference between 1 or 2 months stopped and 12 months stopped, but there was a very lower major secondary bleeding endpoint. But as you can see, there is a difference into 1 to 2 DAPT and 12 months DAPT, but not statistically different. So we have to think about what is the best antiplatelet therapy in these groups. And in the P2Y12 monotherapy, ticagrelor after short DAPT, as Dr. Chanjun Kim shown, Twilight trial, TICO trial, monotherapy with TICA 3 months, after 3 months, can be very useful options. So how about prasugrel monotherapy after short duration of DAPT? Best antiplatelet strategy for CHIP ACS. There is some interesting studies in Japan, as I said, pilot study. It was a multi-center single-arm open-label study, pilot trial. It was a complete omission of aspirin immediately after PCI. So study was done in relatively not high risk. Syntax score was lower than 23. So loading with DAPT at least 2 hours prior to PCI, then optimal result, then loading prasugrel immediately after PCI, and after PCI, aspirin discontinued. So 201 patients were screened and 1 cardiac death. So after 4 months, 1 patient who died after 3 days. There was no bleeding endpoint or stent thrombosis. So it was like this: clopidogrel, aspirin, loading. Then after the PCI, only prasugrel mono. So in Japan, they made this as a more study, not a pilot study. So you can see 214 and 1 month follow-up and 3 months follow-up. But in this group, just those prasugrel, 20 milli of loading dose and 3.75 of maintenance dose was used. As you can see, after 3 months, there was no problem with the prasugrel monotherapy with 3.75 milligrams safe and feasible. Of course, we have to think about the longer terms and longer effects, but in this study, in selected patients, we can only use prasugrel monotherapy even just after PCI, maybe. So this is the future prospects of this study group doing maybe prasugrel maintenance dose after day 1 of PCI as 1 year follow-up. So this is Prado-CHIP as we are doing. We are using aspirin prasugrel for 1 month, and with patients without major ischemic or bleeding events randomized in the 1 month, and we are going to do de-escalation group, aspirin clopidogrel, and a potent P2Y12 monotherapy group as prasugrel. So we are doing this 1-to-1 randomized trial as an inclusion criteria is like this. So ACS with CHIP patients definition like this. So 2,000 people we are trying to enroll. 394 patients has been randomized. And status left main 60 cases, OS 42. There's a long region too much, so we're concerning about this long regions. So this is how it has been done. Actually, this is my last slide. So I think there are many things about using antiplatelet PCI. So we have to do studies, but personalization of antiplatelet PCIs is important. Thank you for attention.